Noches tengan todos ustedes. Muchas gracias por unirse nuevamente a nuestras sesiones de la Sociedad Peruana de Neurocirugía. En realidad han pasado muchas cosas esta semana, sobre todo en la FLANC, en la Federación Latinoamericana de Neurocirugía. Y ya les vamos a ir haciendo un resumen. Y en honor al tiempo ya vamos a empezar con esta reunión, que agradecemos a todos nuestros panelistas. Good evening, everybody. Welcome to our 9th extraordinary session of the Peruvian Neurosurgery Society. As you know, the current board of directors of our society has been promoting the participation of the Neurosurgery Subspecialties Committee. Tonight, we have on the agenda the participation of the Tumors Committee with the program that you already know. We thank Dr. Mahua Day for your participation tonight and for sharing her research with us. So now we start giving the word to Dr. Jaime Lopez to conduct the program as Secretary of Scientific Action of our society, who will command this event. Thanks. Jaime, please.
Okay, thanks, Dr. Duran. Good night, everyone, to our speakers, and moderators, and panelists, and the participants from Peru, South America, and some people from Asia and Europe too. So that's we are starting the first international webinar with another language different like Spanish. First of all, I'm going to share my screen. Well, tonight we have an international webinar in neuro-oncology. Our guest speaker is Dr. Mahua Day, and we have some moderators and panelists that Dr. Alicia Becerra is my co-moderator tonight. He's a neurosurgeon, a chief of functional and neurointerventional section of Edgardo Rebagliati Martin Hospital in Peru, one of the biggest hospitals in our country. Thanks, Dr. Alicia, for being with us tonight. Dr. Juan Carlos Samamé Perez Vargas is a clinical oncologist. He's a member and the coordinator of the Cancer Committee in Loaiza National Hospital. Thanks, Juan Carlos, for accepting our invitation. Next one is Dr. Sandro Casavilca Zambrano, is the chief of the Tumor Tissue Bank and member of the surgical pathology staff of the Neoplastic Disease National Institute. Also, he's a CNS tumor consultant and one of the best neuropathologists here in our country. Thanks, Dr. Sandro, for accepting our invitations tonight. Dr. Luis Ojeda Medina is a neurosurgeon, neuro-oncology surgeon of the same institute, the National Neoplastic Disease Institute. He's one of the more experienced neurosurgeons in oncology field in our country. Thanks, Dr. Ojeda, for being with us. And finally, our guest speaker, international speaker, is Dr. Mahua Day. He's a a good friend since 2009, where we met, where we were both residents in Rosario. She was doing the residence program in the University of Chicago. After finishing the residency, she did a fellowship in neuro-oncology in the University of Chicago too. After some years now, she's an assistant professor and director of the surgical neuro-oncology program at the University of Wisconsin School of Medicine and Public Health. She's very involved in the study and doing surgeries and basic research in gliomas. So tonight it's a good pleasure to have Mahua in front of our national and international neurosurgeons. And again, Mahua, thanks for our invitations. And I'm going to stop to share the screen. And so, and now you can share your screen. Mahua, start with your presentation. Thanks.
Thanks a lot, Jaime. Thanks for the invitation. It's really a pleasure to be here and seeing Jaime after a long time. Actually, I saw him last year at AANS, but as he said, we've known each other for some time when he was at University of Chicago and I was a resident there. So, and thanks everyone in the committee for inviting me. I'm gonna start sharing my screen now. Somehow it says I have to quit and re-log in for me to share the screen. So if you just wait.
Yeah, we'll wait for you. We'll wait for you.
Okay, thank you.
Yeah, it's okay. Don't worry.
Okay.
Can you see my screen?
Perfect, perfect, Mahua.
All right, so I'm going to talk about immunotherapy for malignant brain tumors. It's a little bit of the background on glioma, why immunotherapy evolved in glioma, what are the trials that led us to where we are, and some of the research that we're doing in my lab, and what sparked my interest in immunotherapy per se. And then what does the future of immunotherapy looks like in glioma? So, I mean, for this audience, I don't think I have to belabor this point too much. Malignant glioma is a devastating disease, has poor prognosis, very difficult to treat. It's almost 100% recurrence rate. epidemiologically, if we look at it, it's about 4 cases per 100,000 males worldwide, and about 3, so a little bit of a male predominance, and it's a little more predominant in developed countries compared to underdeveloped countries. Now, if we take all CNS tumors, majority of them are non-malignant tumors, and meningiomas, pituitary tumors, they fall in that category. Of all the malignant tumor, majority of them are glial in origin. And of all glial tumor, majority of them are GBM. So if we look at age-wise, it's a disease of older people. The higher incidence rate we see in higher age group, and a little more white predominance and a little more predominance for males. It's a disease of supratentorial compartment. Majority of these arise in the cerebral cortex. A very small fraction of these arise in infratentorial compartment. Now, histologically, we used to grade them based on how they looked under the microscope, with grade 1 through grade 4, grade 1 being the lowest grade and grade 4 being the highest grade. After TCGA was sequenced, then gliomas started being classified based on specific gene signature into proneural, neural, classical, or mesenchymal. And if we look at how they originate, majority of them originate as primary glioblastoma with specific gene signature that's associated with them, versus 10% of them, they arise as low-grade gliomas, but eventually they mutate their way up to a higher grade tumor. However, if we just look at the grading, grade 1 versus grade 4, all the patients who are diagnosed with grade 4 GBM, they don't have homogeneous prognosis. Prognosis varies even within a specific grade. Younger patient in all grade do better than older patient. If they have MGMT promoter methylated, they do better with chemo and radiation treatment versus if they have MGMT promoter unmethylated. If they have IDH mutation, that also determines prognosis. If the IDH is wild type, they have significantly less overall survival compared to IDH mutant type. So what it really tells us is just a histological grade does not give us the whole picture of the disease. And like most things in life, devil's always in the detail. So what drives these tumors are the underlying mutation combined with their combined molecular profile. And it's not just how they look under the microscope, it's their mutational status that determines their behavior. Taking all that into consideration, World Health Organization 2016 revised their characterization of these tumors and took this molecular grading into consideration. So now glioblastoma is defined as glioblastoma that's IDH mutant versus IDH wild type. That's because patients with IDH mutant glioblastoma, they have significantly better overall survival compared to glioblastoma with IDH wild type. And the current standard of care is defined by 2 papers that was published by the same group. Initially, Stoop showed that adding Temodar to radiation increased survival in this group. And then recently, a last paper published in 2015, they showed that adding tumor treatment field adds another few months to the overall survival, taking it up to about 20.9 months with the combination of surgery, chemo, radiation, and tumor treatment field. Now, all neurosurgeons who treat this disease know the frustrating part of treating this disease is no matter how good a job we do with surgical resection, this disease always comes back. we have made a lot of progress, technical progresses in terms of surgical resection, where we can maximize the amount of tumor we can take out in terms of having better imaging system with better functional capabilities, and with 5-ALA and fluorescein that can help us see the tumor. With all of these advances, we haven't really advanced patient survival that much, because eventually they all come back, and it's a frustrating disease. So majority of the neurosurgeons who treat this disease eventually end up looking at what can we do better for our patients. And unfortunately, surgery is not the answer here. Surgery is the cornerstone for this disease. We need to debulk the tumor, we need tissue for molecular characterization, but eventually it all recurs, and that has to come from further studying this in the lab. And that's what motivated me to go and work more in the lab to help figure out how we can do better for our patients who are suffering from this. Because as I said, if you look at all cancer demographics for last 30, 50 years, there came a point when their overall survival started significantly getting better. However, brain tumor is one of those that if you were diagnosed with a malignant glioma back in 1970s versus if you're diagnosed with it today, not much has changed in terms of big significant difference. We have gained few months here and there, but nothing like what we have seen in terms of lung cancer or breast cancer. So although the incidence rate is not high, this disease definitely needs our attention. So why immunotherapy? I'm a little biased. The reason I think immunotherapy has a pretty significant role in disease, because if we look at epidemiological papers where they have shown that people who had history of allergies or asthma, when they grow up, they have less likelihood of developing glioma. Initially, it was an observation. However, later, paper published by this group showed that single nucleotide polymorphism in asthma cytokine-related genes such as IL-4 and IL-13, all the SNPs that were related to asthma had inverse correlation with patients' risk of developing glioma later in their life. This was even a more interesting study that was done in Sweden, where they were following a cohort of patients for developing cardiovascular risk. They were collecting these 350 patients, their blood, and they followed them for many years for their risk of developing cardiovascular disease. Within this cohort of groups, 512 patients eventually developed glioma. Now, this group, Schwarzerbaum, they went back and they looked at the serum of these 512 patients, and what they saw that as early as 15 years prior to them getting glioma, they started seeing differences in the cytokine genes that were associated with allergy and asthma. And close to 5 years prior to developing glioma, they have significant dysregulation of cytokine genes that were associated with allergy and asthma. So what it really tells us is that immune dysfunction in these patients started many years prior to them getting glioma. And that postulated a lot of hypotheses as to what may be the mechanism, why these patients who had history of allergy or asthma have a lesser risk of developing glioma. And one hypothesis is that if you have allergy or asthma, you have a hyperactive immune system. And a hyperactive immune system is also much better at immune surveillance for precancerous cells that may be accumulating mutation, which will eventually become cancerous. Another hypothesis is that allergy and asthma is a disease of dysfunctional regulatory T cells. If your regulatory T cells these are suppressive cells that suppresses your immune system. If they're not very functional, you get a hyperactive immune system and you get allergy and asthma. However, many studies eventually showed that GBM is a disease where regulatory T cells are very active. They modulate many functions of immune response within the tumor and create an immunosuppressive environment. So a lot of interest went into regulatory T cells and their role in gliomagenesis. From there, the branch of immunotherapy that started developing within the malignant glioma world. The immunotherapy is a spectrum of therapeutic strategies that uses your host immune system to selectively destroy malignant cancer cells. There are many ways to use therapeutic strategies. Immune system can be activated by vaccination, by immune checkpoint blockade. We can engineer T cells that are specific to various antigens that are specific to the tumor, oncolytic viruses that can target cancer cell and cause cancer cell lysis. And all these strategies have been tried in glioma, not with much success. However, I just want to highlight a couple of clinical trials in each category. Although it didn't show overall benefit, but we learned every failed trial, in my mind, is also an opportunity for us to learn as to what worked and what did not work. So in terms of CAR T cell, engineered T cell, the concept is fairly simple, that once we take out the tumor has T cells that are infiltrating the tumor. We can isolate these T cells out. We can clonally expand these T cells, and then we select them for tumor antigen. And then selectively we expand these tumor-specific T cell, and we can give this back to the patient. Or we can engineer these T cells specific for a specific antigen that if we know the tumor is expressing. IL-13 receptor alpha CAR is one of those engineered T cells that was tried in a patient whose tumor was overexpressing IL-13 receptor alpha. This was one patient that was reported. It showed very dramatic radiological response. However, we did not see any clinical benefit. And again, it was a one-patient study. There was no efficacy shown or published so far that shows efficacy in a larger trial. On the other hand, tumor vaccines are interesting in themselves. Vaccines can be peptide vaccines or cell-free or cell-based, dendritic cell-based vaccines. So Rindapepamu, which is a EGFR variant 3 version of peptide vaccine. I worked on this when I was a medical student, and initially phase 1-2 trial, it did show dramatic response. When tumor recurred, it was always EGFR V3 negative. So tumor can select out antigens that if we target one antigen at a time. And when we tested this in a large phase 3 clinical trial, we did not see any survival benefit to the treated versus untreated group. Versus DCVax, this is a vaccine that UCLA group worked for longest time. Now, they recently published the result for this. And interestingly, what they showed in their trial, that there were a population of extended survival, that patients who survived almost 40 months, which is double the survival of current standard of care. The only problem with this trial was that the trial allowed crossover. So if tumor recurred, patient could opt into the DCVax arm. And as we know, all glioma recur. So eventually everyone ended up getting the vaccine. So it didn't really show the efficacy because it wasn't a truly randomized trial at the end, but it did show that in a certain group of patients, they do respond to this strategy of vaccination. And in terms of viral vector, the concept is that you design a virus that will specifically target your tumor cells. It will replicate inside the cell, and then it'll slice the cell and release more viruses, which will propagate and infect nearby cells and eventually lead to killing of all the tumor cells. Now, many different viral vectors have been used. The most trial that got most attention was probably this poliovirus trial. This was from the Duke group. Again, trial overall did not show a survival benefit, but they again showed there was a group of patients who did benefit from this virus treatment. So what we are seeing over and over from these immunological trials, that although the trial don't show a mass difference where we're seeing an overall survival difference, there are a group of people who respond better to immunotherapy. Now, if we can somehow pre-pick these people who we think will respond better to immunotherapy and enroll them in clinical trial, maybe we will see actual differences in that population. Now, what makes some people respond and others don't, that is a learning opportunity for us from all of these clinical trials. And the other strategy that has been currently most center stage in terms of immunotherapy is monoclonal antibody. Now, everybody in neuro-oncology knows about anti-VEGF monoclonal antibody, which is the bevacizumab or Avastin. It is used pretty commonly in neuro-oncology. However, 2 large phase 3 trials did not show an overall survival benefit of bevacizumab over the group that did not get bevacizumab. But another monoclonal antibodies that are currently changing the game for many cancers, such as melanoma, lung cancer, are checkpoint inhibitors. So activated T cells, they need double signal to actually kill a tumor cell. The second signal is an activating signal. However, tumor can stop the activation of these activated tumor cell by these checkpoint inhibitors. These antibodies selectively bind to these inhibitor and stop this interaction and keep these T cells activated, which leads to dramatic survival advantage in terms of lung cancer and melanoma. With that, we tried this in a recurrent GBM setting. The Checkmate 143 trial was a phase 3 trial of anti-PD-1 versus anti-VEGF antibody, and the trial did not show any survival benefit. However, as I said, every failed trial, I think, is an opportunity for us to learn that what caused the failure. And there was the 3 papers that were published in a cluster in Nature, kind of trying to figure out why we keep failing in GBM versus the same strategy is successful in other cancer. This first study that was done by the UCLA group, what they showed that using neoadjuvant checkpoint inhibitor prior to tumor resection actually increases T cell diversity, and that the patient with higher T cell diversity, they have a better response to checkpoint inhibitors. However, what more interestingly, what they pointed out is that not, again, every patient who were treated had the same response. Patient 5 and patient 10 had pretty good T cell response. They had high number of CD8s in their tumor. However, patient 24 and 33, the tumor inherently had very few T cells in them. So in these patients, even if you treat them with checkpoint inhibitor, they're not going to see the benefit of checkpoint inhibitors. So one important thing is interpatient variability, and the other is maybe we need to treat them with checkpoint inhibitor prior to taking the tumor out. This way, the T cells that are specific to the tumor antigens, they are still there, and they have their checkpoint inhibition taken off by the checkpoint inhibitor. This study was published at the same time from a group in Spain. They also did the same thing. They treated patient prior to tumor resection with checkpoint inhibitor and then resected the tumor. And they also showed patient who had high TCR diversity, they had a better overall survival compared to patient who had low TCR. Again, what they're telling us, these trials, that patients who have whose immune system has diverse T cell clonality, have more diverse TCR, they respond better to immunotherapy compared to patients who don't have the diversity of the TCR. And this other trial that was published by the Columbia group, what they showed is not just the immune system or the TCR variability that's important. What's also important is what your tumor looks like. They compared the responders versus non-responders from the Checkmate 143 trial, and what they showed that the tumor that had high MAP kinase pathway activated, these were the patients who were the responders. However, patients whose tumor have high PTEN activity, they all clustered into non-responder groups. So taking these three papers, I think what it tells us that, one, we need to have tumor that is tumor characteristic that is favorable, and we need to have patients' immune system that have diverse clonality. If we combine those two, those will be the patient who will benefit most from immunotherapy compared to the patient whose tumor has non-favorable characteristic and their immune system is not that diverse. So if we have to define obstacles that we need to overcome to define successful immunotherapy in glioma, is one, we need to address tumor heterogeneity, and two, we need to address T cell dysfunction within the tumor. If we look at the mutational burden of all the various cancers, the immunotherapy worked really well for skin cancer, lung cancer. Now, if you look at the mutational burden of these cancers, they are very high in their mutational burden. Compared to gliomas, they fall somewhere moderate to low mutational burden. And when we looked at mutational load based on different grades, maybe we would think that high-grade tumors will have high mutational load, but that is not true. Even grade 4 had pretty medium to low mutational load. So in general, gliomas are cold tumor. They're not hot tumors. And on the other hand, there's a wide array of T cell dysfunction that has been described within the glioma microenvironment, which starts from energy, exhaustion, senescence. All of these have been described within glioma. And this work by the DO group, they showed that of all the tumors, gliomas had the highest number of exhausted T cells in the tumor microenvironment. So GBM induces T cell exhaustion at a much larger scale than other cancers. So with that background, in my lab, we focus on both of these aspects of immunotherapy, both how we can turn a cold tumor into a hot tumor, and how we can overcome the T cell dysfunction that we're seeing within the tumor microenvironment. Now, in terms of mutational burden, currently we're looking at it in metastatic tumor setting. If we can increase the mutational burden by radiosurgery. So I have a clinical trial currently where we're looking at the efficacy of pre-op radiosurgery. What we're doing is doing the radiosurgery to the met, and then we're resecting the tumor, and then we're analyzing the tumor for their DNA, RNA, and their mutational load to see if we can actually increase the mutational load within the tumor by using radiation. And on the T cell dysfunction side, we're looking at how can we make more directed immune response within the tumor microenvironment. So we started looking at first defining the endogenous immune response, because to manipulate a system, first we really have to know the system. So we wanted to see what do the intratumoral immune response look like in a very simplistic way. Dendritic cell has to see a cancer cell. It digests the contents of the cancer cell. It picks up certain peptides. It shows that peptide antigen to a naive T cell. Based on this interaction, a naive T cell can become a Th1 or a Th2 or a Th17 or a regulatory T cell. Now, what determines which lineage will this naive T cell commit to really depends on the context this antigen is being presented to the naive T cell. So first we wanted to see what kind of immune response does GBM induces. What we noticed that with both compared to the blood, in the tumor microenvironment, the T cells, CD4 T cells, were all four lineages. There were Th1 positive, Th2 positive, regulatory T cell, and Th17. So there was no one directional immune response. It was just a scattered immune response that was going into all directions. Interestingly, what we noticed that there was a large population of dual positive T cells. They were both Th1 and Th2 positive. Now, to have an effective anti-tumor immune response, we need to have a strong Th1 response. Although we see some Th1 response within the tumor microenvironment, what we see is a much bigger response of this Th1, Th2 cells, which tells us that this cell has an inherent plasticity in it that maybe we will be able to push them to go towards Th1 instead of going towards Th2. So we started looking at what determines this lineage differentiation within the T cell. What we learned from basic immunology is the DNA methylation pattern. That's what determines the lineage specification of T cells. Now, DNA methylation can be of two types. There are two distinct set of enzymes that are responsible for DNA methylation. DNMT3, which methylates a de novo DNA strand. So this is seen in embryogenesis. When embryo is being formed, that's when DNMT3 puts methyl groups at various C sites. And we don't know exactly what drives DNMT3 to selectively select these sites to methylate. But once this initial methylation pattern is established, when this DNA replicates, DNMT1 methylates the sister strand of the methylated strand based on the methylation that was established by DNMT3. So what we did is we took all the T cells from the patient. We wanted to see the methylation pattern within the CD4 cells. So what we did is during surgery, we isolated the tumor and the peripheral blood. From both blood and tumor, we isolated CD4 T cells. And we did whole genome bisulfite sequencing and RNA sequencing of CD4 cells. We also did RNA sequencing of the tumor cells to see what was the crosstalk between the tumor and the CD4 cells that were infiltrating within the tumor. What we found, very interestingly, is that the genes that were methylated in the blood were unmethylated in the tumor microenvironment, and vice versa. And if we look at interpatient variability, all the CD4s of all 5 patients in the blood, they pretty much had similar methylation profile. However, once these CD4s go into the tumor microenvironment, their methylation is different for different patients. So there is pretty significant interpatient variability, which is again what many trials have shown us, but here we see actually mechanistically that the methylation pattern of these CD4s that are within the tumor microenvironment are different between patients. Then we looked at the methylation sites as to where these differentially methylated regions were located, and majority of them were located in the promoter region, and they clustered around the transcription start sites. So what it tells us is that the DNA methylation might be a mechanism by which tumor regulates the immune response within the tumor microenvironment. Again, we saw the similar pattern with the PCA analysis, that the peripheral blood CD4s from all the patients, they pretty much looked similar in terms of their methylation signature. But once they make it into the tumor microenvironment, they had pretty distinct signature that was specific to individual patients. Then we wanted to see if this methylation pattern was also being reflected in the gene expression pattern. So we looked at the differential genes expressed, and we again noticed that there were genes that were differentially expressed within the tumor versus blood. So once the T cells circulating in the blood make it to the tumor, they go through epigenetic changes of the DNA methylation that results in gene expression changes in these cells. And Pearson correlations showed that there was a negative linear relationship. So the more methylated they were, the less likely that the gene was expressed, and less methylated they were, the more likelihood the gene was expressed. So again, it's in terms of the directionality of the immune response, we noticed that each patient had a very different immune response, such as patient 8 had a pretty strong FOXP3 response. So did patient 9, versus patient 10 had, a pretty strong Th17 response. So not every patient mounts the same immune response, and is the characteristic of the tumor that's driving the immune response within the tumor. And in terms of combined gene expression and methylation, all the lineage determining genes, they fall somewhere in the middle, where they are what matches with what we saw, that the immune response within the tumor microenvironment is not directed in a specific lineage. It's a mixed lineage immune response. And in terms of gene expression and methylation correlation, the Th1, Th2, and FOXP3 gene signatures correlated more between all the groups compared to individual patients. And in terms of transcription start side and methylation relation, again, what we saw that there is a differential methylation of Th1, Th2, and FOXP3 that fell closer to transcription start site. So we think these 3 genes are probably more likely regulated by epigenetic DNA methylation than any other lineages. And when we compared the methylation profile with gene expression profile, we saw the genes that were highly methylated, they were less expressed, versus genes that were less methylated, they had higher expression. And lineage-wise, they did correlate, but it's not a one-to-one correlation, which implies that DNA methylation is not the only way to regulate immune system, immune response within the tumor microenvironment. In terms of pathway analysis, we wanted to see which pathways are mostly regulated by DNA methylation and gene expression combination. And what we noticed that the methylation that pathways that were related to activation of immune response, T cell aggregation, these were all hypermethylated within the tumor. So what it's telling us is that tumor actively hypermethylating pathways that causes T cell activation. As a result, the genes are downregulated, and we're not inducing a strong enough immune response within the tumor microenvironment. And to see how the tumor crosstalk is affecting this, we looked at the corresponding ligands and receptors, and we found that many receptors that were upregulated in the on the CD4, their corresponding ligands were also upregulated within the tumor. So is the tumor T cell crosstalk that is determining the immune response that's taking place within the tumor microenvironment. So in terms of mechanism, since we saw that is the methylation that's determining the functionality of the CD4 cells, we wanted to see which molecule regulates this gene expression pattern. Now, we did a co-IP, and EZH2 and DNMT are the 2 most commonly known epigenetic modifiers that epigenetically modifies DNA strand. What we found that compared to the blood, the CD4 T cells that in the brain, one, they had a different isoform of EZH2. When we co-immunoprecipitated them with the DNMT1 and DNMT3, we saw in blood, EZH2 co-immunoprecipitated with DNMT1. However, in the brain, it co-precipitated with DNMT3, but we did not see the same response in the blood. This made us think that it's DNMT3 that's causing the methylation changes in the CD4 T cells that are in the tumor microenvironment. And maybe by targeting this, we can control the methylation pattern of the immune cells that are in the tumor microenvironment. So currently, we are working on a mouse model to see if we can regulate DNMT3 and in turn regulate the immune response within the tumor microenvironment. So in summary, from all this data, what we can conclude is CD4 T cells undergo significant epigenetic changes. There's an endogenous immune response that varies between patients, and GBM can alter CD4 phenotype. So although we're using a mouse model to understand the mechanism of this, one of the bigger problem, I think, in terms of glioma research is a lack of a good model, because I think this is the model that we have and this is the disease that we're treating. And unless our model is a good reflection of the disease we're trying to treat, it's very unlikely that we're going to come up with a successful treatment strategy, because many studies that have looked really promising in preclinical model, when they go into clinical trial, they fail miserably. So one of the other things that we're doing in my lab is we're also exploring this option of comparative oncology. What it is using a spontaneous model of a brain tumor that is a larger animal model, and using that as a therapeutic trial model. So dogs, just like patients, they develop brain tumor. They live in the same environment that we do, and the tumor they develop, it's developing in an immunocompetent host, and it's a spontaneous tumor. So if we can integrate that within our clinical trial and our basic research, I think we can come up with more successful preclinical studies that will lead to better predictive marker of if these trials will succeed in patients. So canine brain tumors, there are about 20 per 100,000 dogs per year. You know, their peak age of diagnosis is about 7 to 8 years, which is same as older adults. The risk factor in dogs is being brachycephalic. So short-nosed dogs, they develop gliomas like boxers and Boston Terriers. They present very similar to patient. They present with seizures. That's in mice, we never see this, but this is a dog who's just playing with the toys, and now he's having a seizure. So their presenting symptoms are very similar to human. They're in immunocompetent hosts. They are much better for surgery and previous and subsequent treatment strategy. So we wanted to define this model better so we can use, at least for immunotherapy, it's a great model that we can define better. So histologically, canine brain tumors, they look very similar to human brain tumors. They have similar staining for GFAP, OLIC2. Even on MRI scan, they look very similar to human tumor. Here's a human GBM. This is a dog with GBM. Here's a human grade 2 oligo. Here's a dog oligo. So imaging-wise, it's easier to follow them. So we wanted to define them in terms of their gene expression. And again, we saw similar pathways that were dysregulated in human GBM are also the pathways that are dysregulated in dog gliomas. And similar genes, P53, PDGFR, RA, DNNT1, OLIC2, NF1. These are the same genes that we describe human gliomas that are also dysregulated in canine glioma. And in terms of their immune makeup, they're also very similar to human gliomas. They are infiltrated with CD4s and CD8s. They have regulatory T cells in their tumor microenvironments. In terms of these cells that are the T cells, they also express PD-L1, PD-1, CTLA4, the checkpoint markers that we see in human gliomas are also seen in dog glioma. And then similar dendritic cell makeup that we see in human glioma, we also see in dog glioma. So with defining their basic immune makeup, what we showed that this is a good model that we can use to test immunotherapeutic strategies that we are showing in successful in mice model before taking it to human to bridge that gap so we're not failing in large clinical trials. With all that said, I think where my lab is going and I think where the future of immunotherapy is going, one, I think immunotherapy is going to be a successful strategy for GBM because it's a disease that manipulates the immune system. So if we can manipulate it in our advantage, I think we will make a difference. But the what will make this success possible are these new tools that are coming into play that we were not, sequencing a tumor was a big deal few years ago. Now, we're sequencing all our tumors on a regular basis. So this deep sequencing, single cell genomics, and bioinformatics tools that can bring all of this and have some predictive algorithm, that's really what's going to define the immunotherapy of the future. And it will be based on, one is the T-cell receptor repertoire. As we all get older, our TCR repertoires go down. So that's something we have to keep in mind in terms of all cancer, and specifically GBM, which is a disease of older patients. The TCR variability is another thing that's very important, because all of us are exposed to different environment. All of you in Peru are exposed to different antigens than all of us here in the United States. So our immune systems recognizes different things. So for us to think that someone sitting in Peru will induce the same immune response to something as someone who grew up in the United States and saw a very different set of antigen, it's a little bit of naive thinking. And that's why the immunotherapy, in my mind, is the final frontier of personalized medicine, because we have to bring in three distinct things together. We have to bring in the characteristic of the tumor, the peptides that are individual to a patient's tumor, that patient's own immune system, and its own TCR variability. If we can bring all of these three things together and customize vaccine, that will lead to the best possible immune outcome. And recent clinical trials have recognized that, and they are going in that direction. Here are the two phase 1 trial that I think are looking very interesting, where they are using unmutated vaccine and then personalized mutated vaccine based on each patient's mutation. And what they show that combining these is inducing a predominantly Th1 type CD4 immune response. What we've shown in our data, that tumor itself doesn't do it, but if we can specifically pick antigens that are patient specific and vaccinate them with them, this personalized vaccine mechanism generates a strong Th1 type immune response. And this other trial that was coming from MGH, where they showed that, again, the strategy of personalizing vaccine using patient's own tumor and their own immune system, the patient generates significantly high number of CD8 T cells that are able to produce multiple tumor ocidal cytokines. However, they also show high exhaustion markers. So combining something, a personalized vaccine with a checkpoint inhibitor, is probably going to be the future of immunotherapy is going to look like. And with that, I think I'm going to finish my talk. I have nothing to disclose. There are many grants that support the work that we do in the lab, and many people in the lab have worked on all the data that I presented. And thank you. I'll take any questions.
Thank you.
¿Alguna pregunta?
Thank you very much, Doctor.
Mahua, could you stop to share your screen, please?
Yes.
Thank you, Mahua, for your amazing lecture. It's a really new world for most of us neurosurgeons in our country. But I'm not sure if when we have some questions or Dr. Ojeda or Dr. Samame, Dr.
Yeah. Yes. Good morning. Good night. A very nice presentation, Dr. Mahua Day. It's nice to see different kind of work in glioblastoma and immunity. I have one question. Have you ever studied what happened when we take glioblastoma and put then in another tissue different than brain, such as muscle, hepatic, another? Because we know that different tumors have affinity for different tissue. So what are the response of the body in such cases where when the tumor is in other place, the immunity differ? Can we use that for enhance the immunity of the patient?
You know, that's a great question. So the immune system is very organ specific. When we grow these tumors in the flank of a mice, we see a very different immune response compared to if you put the tumor in the brain of the mice. So it's the tissue microenvironment that determines the immune response partly, and not just the tumor. So and it's better shown in metastatic model, you know, melanoma, when it's on the skin, it works very well with checkpoint inhibitors, but then once melanoma metastasizes to the brain, that response drops drastically. So there is a local microenvironmental effect on the immune system.
Yeah, but when you use the tumor as a vaccine, where do you put the tumor? In the skin, in a muscle?
So
Where
for
is
the
the better?
peptide vaccine, yes, subdermal on the skin.
Subdermic.
Okay, thanks.
So for peptide vaccine, yes, it's on the skin, and we look for like hypersensitivity reaction on the skin. But
Okay.
as I said, that strategy for rindapepimut, it worked, you know, but on a large trial, it did not show any efficacy.
Mm-hmm.
Thanks, Mahua. Juan Carlos?
Hello. I want to thank to Dr. Mahua because they made a very nice talk and very provocative. And I want to, first of all, make a congratulation to her because the field of the research field that she's moving is very, I think that she's living the future right now. In terms of glioblastoma and all the central tumors. Well, first of all, in my perspective of medical oncologist, glioma is a very, very challenging tumor. Sometimes becomes more or less frustrating because the weapons that we have are not so much. In the last few years, we had a little of hope when appeared some kind of immunostrategies, because I think that in this field, the immunotherapy or the appearance of immunotherapy in cancer therapy in general we have very hope for that. But the problem is it's in the big picture, but when we focus on this setting, we don't have a lot of results. We move into, as doctor said, into a lot of strategies, but the very particular tumor environment and the tumor landscape of gliomas are very, very challenging. We try for some vaccines, CAR T cells, oncolytic viruses, add to oncolytic viruses some chemotherapy like temozolomide, adenovirus, but we have a lot of phase 1 and a lot of phase 2, but we don't move in this. Maybe we don't have a lot of phase 3. Last month we had the ASCO, the American Society of Clinical Oncology Symposium virtually because of the pandemic of the COVID, and we have more or less 130 abstracts in the setting of central tumors, and only 15 talking about immunocheckpoints. So I think that when we saw the results of this, we are talking about maybe near to 80 clinical trials that is moving only in phase 1 and phase 2. So I think that we want to move in that direction, but the tumor are very complex, and you show us, because all of your research moved that the environment is very, very particular, and it's challenging us to try some strategies. I'm very, very convinced ctDNA, so RNA DNA, circulant or CTC, tumor cancer tumor cells. I think that we have to move in that scenario to have more answers and more strategies and try to solve this problem. For me, is in the perspective of a medical oncologist, is very challenging, but I think that we are starting right now. We don't have any or so much results that we want to have for our patients.
Mahua?
Yeah, no, I 100% agree. I think, one of the reasons why people lost a little bit interest in immunotherapy was probably when the Checkmate 143 failed. And people were like, it worked for every other cancer, it failed for a recurrent GBM. But I also think we're being a little naive for us to think that brain will work the same way as skin or lung. If you think about skin, lung, these organs are seeing outside environment constantly because we're breathing outside air. Our skin is in touch with outside environment 24/7. So the antigen repertoire that these organs have is vast, versus brain lives in a closed box, never sees the daylight until we operate on it. So to think that that organ will have exactly the same immune repertoire as the skin or the lung is naive thinking. So I think, like you said, we have to understand the organ better, the tumor better, before we can say what strategy will work right. And I think now more people have realized that, and more people are doing those kind of studies, like those neoadjuvant PD-1 in the recurrent setting, what they're showing that if we give them the checkpoint inhibitor before we dissect the tumor, then maybe we're taking off the brake of those specific T cells that went into the tumor microenvironment and can be clonally expanded. So I think the more we understand, the better our study design is going to get, and the better our clinical outcome will be.
I totally agree with Mahua, and I think that maybe one of the more strategies are to become hot this cold tumor, and I think that in that setting, I think that the radiotherapy or neoadjuvant strategies with radiotherapy plus anti-CTLA-4 or plus anti-PD-1, I think that maybe in that way we can have more achievable results. I think that you said the nature of the tumor, of this tumor, is very, very unique. So we have to move and to understand first, and then to design some strategies. And I think that are very, very practical tip to move and to try to have some results.
Thanks for your participation, Juan Carlos. We have some questions here, Mahua, in our box. Dr. Gerson Flores, who is a neurosurgeon in the General Hospital, one of the biggest hospitals here in our country, said, excellent presentation. Based on your research findings, could you say that GBM is a systemic disease with genetic heterogeneity and high immune component distinct a local disease of the brain, as we generally consider it?
No, I think the immune effect of this is systemic. It's not just localized within the tumor microenvironment. The T cell dysfunction that we see in GBM patient, it's in their blood, not only in their tumors. So immune system wise, you know, the good and the bad about immune system is whenever we talk about brain tumor, the other thing we talk about is blood-brain barrier. A lot of drugs work for other cancer that doesn't make it to the brain because of the blood-brain barrier. Immune system, in one way, is not bound by blood-brain barrier because T cells know how to cross the blood-brain barrier and go to the other side. So that there is always a circulation of these T cells back and forth. So the immune effect of this tumor is systemic and it's not just intracranial.
Mhm.
Thanks, Mahua. And Dr. Michael Hinojosa is asking, is there any chance of light of immunotherapy for gliomas grade 1 or 2?
So right now, you know, the most focus is focused on grade 4 just because their survival is so poor. Grade 2s, you know, good markers. Some of these patients can live 10, 15 years with good surgery and if they have positive markers. So majority of the trials right now is in higher grade 3, or I would say 90% of them are in grade 4.
Mhm.
Okay. Well, there are some people very informative to revise those papers. Thank you from Asia. From Mexico, excellent lecture, Mahua. And asking, what are your opinion in alternative treatments like Optune and USCAPs that are being studied? Are they worth pursuing?
So Optune is the same as tumor treatment field. So the last, you know, the big randomized trial that came from Stube group, they did show that adding tumor treatment field to the standard of surgery, Temodar, and radiation does increase survival to 20 months. So the 20-month survival that we're quoting is based on integrating Optune with chemo and radiation.
Okay. There's another question here. Good evening, excellent presentation, Dr. Mahua. Which of the different immunotherapies have shown more promising results? How the administration of the medication is performed?
So, you know, different ones, different strategies. So CARs, they're giving intravenously. The T cells, they're all adaptive transferred T cells. Checkpoint inhibitors, those are monoclonal antibodies, so they're given intravenously. Vaccines, on the other hand, they can be given subdermal as under the skin vaccine. So it depends on what immunotherapy, and viruses, you can deliver locally. There has been trial where the neural stem cells loaded with viruses that are injected locally after tumor resection in the tumor cavity. So the delivery really depends on the agent that we're trying to deliver.
Which one do you think is the more promising in the future? Which one of the immunotherapies do you think is
I think it's going to be you know, the ideal if you think of immune system, it's like driving a car. If you just press on the gas, your car is not going to move. You have to take your foot off the brake and press on the gas for the car to move forward. If you do one or the other, you're not going to see a response. And immunotherapy is going to be the same strategy. You need some kind of immune boosting strategy like a vaccine, and then you combine them with something that takes the inhibition out, such as checkpoint inhibitors. So if you combine those two, I think you're going to see a better response than one versus the other.
Okay, thanks. Dr. Casavilca, yeah.
Thank you very
Go
much.
ahead.
In first place, thanks for your lecture. It's very interesting point. We try to do something of research in immunomodulation and brain tumors. I don't see in your presentation the IDH status of the tumors. And that is important in the survival. Overall,
Absolutely.
H positive is very important because the most longer survival is related to IDH status, even more than with MTMG. That is a point interesting. Another point is the new finding that cyclin-dependent kinase N2K in cases of IDH mutated status have some influence to the worst prognosis from the point of view of genetic. From the point of view of genetic too, we have identified the group of patients that could respond to immunotherapy, like the patient with microsatellite instability, or microsatellite instability syndromes. That is a special group. And we have a question. Well, I try to do research in immunological answer in brain, and the people that try to do that know that it's hard to find lymphocytes in most of the tumors in the brain. The most of the tumors don't have a quantity significant of lymphocytes. And the most cells in the immune response in brain are microglia or macrophages. No? That is controversial, where we have to measure the immune response. If we have to measure the monocytes of the unactivated cells in the blood, or try to find that in the brain. That's an interesting point to discuss too. And for finally, we found when we studied 50 tumors of GBM here in Peruvian population in the institute, and we found some controversial findings, like the tumors that have CD4 positive cells, more CD4 positive cells, have a shorter survival than the patient that have more CD8 positive cells. But the patient that have larger tumors and more survival have more CD8 than the patient that have CD4. And the patient that have CD4, we found that have less methylated tumors. So our population have, in our findings, just 50 cases of complete methylation, just 20%. But in that 20%, have a better survival with treatments. But the patients that have more CD4 positive cells have, the most of them are not methylated. So we try to explain that in our paper with that probably these cells are mutated or have some, most of them regulatory, but we don't have identified with the markers what happened there. So we have a lot of doubts about the topic. Thank you very much.
Thanks for your participation, Dr. Casavilca. Mahua.
What I would say, in terms of CD4 and work, so CD4 kind of orchestrates the immune response. So if CD4 leads to a lot of regulatory T cells, they will have worse survival. And many papers have shown that. So I think that is probably one of the factors that determining worse survival in patients who have a lot of CD4s, because if they're mounting a lot of suppressory T cells, they will have worse prognosis. In terms of not having enough CD8s, now CD8s are the cytotoxic T cells. We want a lot of CD8s because they are the ones that will help kill the tumor. My theory on this is, one, immune system is not designed to take out a giant mass. That's where we surgeons come in play. We debulk majority of it. Now, what's left behind, and as I said, the T cells, they can go in and out of the microenvironment anytime because they're circulating. And we know that immune dysfunction is systemic in these patients. So even though we don't see enough T cell in the microenvironment, I don't think that necessarily means that they will not respond to immunotherapy. If there are enough tumor-specific clonally expanded T cells in their periphery, and if we take out the bulk of the tumor, the residual tumors these T cells can find and take care of them. So yes, if you think of the big tumor, not having enough T cell is a bad thing, but we as a surgeon can help that. We can take out the bulk of the tumor, and the residual T cells, if they know where to find the residual tumor that we can't see or our microscopes can't see, that is, and stop the recurrence, that in my mind is the ultimate goal of immunotherapy.
And about IDH, did you do IDH to this series?
So, majority of the patient who have, as you said, and as you know, IDH mutant patient, they do better. They have better survival compared to IDH wild type. And majority of the grade 4 glioblastomas are IDH wild type. They're not IDH mutant because they're primary GBM. So most of our studies are in IDH wild type, not in IDH mutant population.
Thanks, Mahua. Doctor?
Just to the microsatellite instability have been tested. Have you find some genes? My question is thinking in what kind of tumor marker we can use to choose an immunotherapy. We can choose a tumor marker in the blood samples, maybe. The monocytes is, I understand that is a tendency right now in some kind of research. Or we have to go to the tumor, because I understand that when I take off the tumor, I completely modified the microenvironment and broke totally the barrier. So that will be a clot, no? And that clot will have inflammatory cells. So after surgery, is a complete different situation than before surgery. And maybe we could find some kind of tumor marker to can and do a personalized medicine.
Yeah, and a lot of research is going on in defining those biomarkers. There is no consensus yet as to one marker that will predict responders versus non-responders. But I think majority of the immunology research that's going on in terms of immunotherapy is trying to find out define this group of responders versus non-responders. You're absolutely right.
Thanks. Dr. Ojeda, are you? raising up your hand. Yep.
Yeah, yes. Doctora Magua, thanks again. I have a couple of questions. One, we know that is in the time all the cancer is growing new mutation. What about the immunity in the relapse of glioblastoma? When we have we just gave temozolomide and another treatment, and we have again the tumor. You suggest that we always make almost a biopsy or a resection to have a new profile of the tumor, so we can give a better or another choice of therapy. And what about the stem cell? We know that the stem cell is the cell that is always resisting the therapy. So how do you treat, or how we can work with that in the immunity therapy?
You know, stem cells are interesting. You know, some people will say that there is a inherent group of stem cells that regenerate this tumor. Other groups have shown that any cancer cell that's residual can de-differentiate and become a stem cell and can regenerate the whole tumor under therapeutic stress of radiation and chemotherapy. So I think the jury is still out on that as to if there is a bona fide group of tumor stem cell that if they're left behind, they will regenerate the tumor, or any residual tumor cell under therapeutic stress can de-differentiate and acquire stem-like phenotype, and they can regenerate the whole tumor. You know, most immunotherapy, they're not targeted towards the cancer stem cell because, one, we really don't know what that population looks like. So the immunotherapy is more targeted towards just generic all cancer cells. If you train your T cells to identify, you know, abnormal cell, they will find every cell that looks abnormal to them. And that's why these neoantigen that can develop within tumor, that what we can, when we sequence tumor, we can identify new sequences of peptides that are in the tumor, and then we can cross match with the MHC binding sites on the T cell. If there is a strong affinity interaction, we can use these antigens for personalized vaccine. And that's the trial I was mentioning at the end of my talk, where they are custom making these vaccines for individual patient based on their own neoantigens, and that are much better at inducing CD4 and CD8, Th1 directed CD4 response and subsequent CD8 response.
Thanks. Another question. Can we you show us that there is a difference in the blood and the tumor about methylation. So we had almost two kind of patients before the tumor. So can we, we are doing now in the pandemic, use the plasma of a patient or maybe the cells to make a cross immunity to favor both of the patients?
That's a very interesting thought. I think it would be something to think about. I didn't think about it, but I think that's an interesting thought.
Yeah.
Ha hecho pensar.
Yeah. Thanks.
Well, I think we are going to close the session. Thanks to Doctora Alicia Becerra for your
I'm just listening most of the time.
for being here with us after a long time.
You're so welcome.
Dr. Luis Ojeda, Dr. Casavilca, Dr. Juan Carlos Samamé. It was a pleasure for us. Finally, Mahua, Dr. Mahua Day, thanks again. It was a pleasure to see you again, and thanks for your amazing talk here, and how we can see personally next year, maybe after all this pandemic time will finish in Peru, where maybe in Machu Picchu, like you said before.
No, so thank you so much for inviting. It was a pleasure meeting everybody, and seeing you after a long time. And definitely, hopefully, once the world is back to normal, we can see each other in person.
Okay. Thanks all.
Thank you, Mahua.
Well, Dr.
It was a very nice talk.
Thank you, Dr. Mahua Day, for excellent presentation. Thank you.
Thank you for the kind invitation.
Okay. A todos los miembros de la Sociedad de Neurocirugía, muchas gracias por la presentación, por su asistencia, perdonen, y a los panelistas, a todos ustedes, esperamos tenerlos nuevamente en otra ocasión. A la Junta Directiva, al Consejo Directivo de la Sociedad, por favor, nos reunimos después de finalizada la reunión. Y nuevamente esperamos tenerlos el próximo martes a todos ustedes. Muchas gracias y buenas noches.
Gracias.
Bye, bye. Bye.
Gracias. Thank you, Mahua.
Bye.